congenital hypothyroidism, which is extremely important from clinical perspective, not only from pediatric endocrinology, but also from a pediatrician perspective. So what is the most common feature of congenital hypothyroidism, Dr. Sandeep? Yes. Mm-hmm. So if you have 100 children who have congenital hypothyroidism, what is the most common feature to all of them? Okay. So at 2 weeks, what will be the most common feature, Nimisha? No feature. So that is the biggest message. So if one message comes out of this is that every newborn needs to be screened, because the best of pediatric endocrinologists can identify 10% at birth. And the time which is crucial is 2 weeks. That's when you want to diagnose. It's very, very unlikely to be identified from that perspective. So we need to have a clear-cut understanding of universal screening, which becomes important. So what we'll do is that we'll talk a bit about pathophysiology, then the various causes. A lot of time will be devoted on how do we screen in normal and preterm individuals, and then we will carry forward in terms of management and Q&A at the end of it. So it's part of our MedEClasses lecture series. And so we have now started on thyroid. We have already had series with regards to the various aspects of growth, electrolyte, calcium, obesity. So a lot of it has been done, including the pubertal disorders. So we are focusing now in terms of the thyroid in that regards. So why is thyroid important? Because we can often have confusion in the beginning. So we had this 20-year-old girl with TSH of 28, which was referred for evaluation. Now, there has been a lot of talk about that in terms of what should be done. But what we need to remember here is that this was too early a time to do a TSH. So this clearly was an unnecessary workup at this point of time. And what we could have done is just to repeat it, and it was found to be normal. On the other hand, we may have the missing of cases also. So this is a 32-week-old neonate on routine screening, had TSH of 7, normal free T4, was advised, okay, everything is fine, no need to worry about that. But what really happened in this case was that at day 14, we found that the TSH rose. So what we need to understand is that on one hand, we don't want to do unnecessary or too early workup. We also don't want to miss on these scenarios. There is a missing or messing which happens with congenital hypothyroidism, and this is what we're going to cover in that regards. All of you can go and have a look at our website, learning.growsociety.in, which has a lot of resources related to pediatric endocrinology. There are YouTube resources, including this lecture series. I think there are over 100 videos which are there, which you can have a look at it. Our website provides comprehensive tools and courses related to pediatric endocrinology, including a 2-year fellowship program and a pediatric endocrinology for postgraduate program, which is relevant for various postgraduates across the region. We do run a number of brand rounds, journal clubs, and PG lecture series, so you can all enroll. They are all complimentary in that regards. Our publications include the protocols, the basic and the advanced pediatric endocrinology, and our mobile application will help you guide in terms of day-to-day point of care management from that perspective. So today we are focusing on congenital hypothyroidism. I'll quickly talk about assessment, mainly about the issues in terms of neonatal screening, because that becomes very, very important. So as discussed earlier, pointers, we all talk about hypothermia, jaundice, bradycardia. You may have very, very coarse facies. You may have umbilical hernia. You may have a lot of other features. But the most common feature at the time when you want to pick up congenital hypothyroidism is no feature. So this is something important, and that's why screening becomes important from that perspective. So for any disorder for which we want to do the screening, the disorder has to be common with a significant impact, giving you a lag time, and you should have a good test. So if you look at congenital hypothyroidism, it's common. It's like 1 in 1500 in some of the Indian studies that I said. Maximum you can say 1 in 2500. It is the most common preventable form of mental retardation. You get 14 days because mothers are taking care of the babies. And very importantly, you've got a wonderful test like TSH, which can really screen it. So there is no reason why we should not be doing screening. Now, timing, we already discussed about the surge, so we can go quickly. You can either do at the cord blood or at day 3. Generally, at day 3 is preferred, but some centers with early discharge do use cord blood. There is confusion about what to do in between if you have an earlier one. So you need to have a center-specific cutoff for different gestations. The Indian Society of Pediatric Endocrinology has suggested a different cutoff in the first 48 hours, so you can work accordingly. The important numbers to remember are 40, 20, and 10 as far as treatment is concerned, and 20 and 10 in terms of screening specialty. So first week 40, second week 20, then 10, and then beyond 3 weeks, as Dr. Sandeep was saying, even 6 will become significant. If it's less than 20 in the first week, less than 10 in the 2 weeks, don't worry much about in that perspective. So how do we go about in terms of evaluation? So do a day 3 TSH. If your TSH is more than 40, do a confirmatory FT4 and a TSH and consider starting treatment. If it's less than 20, which is largely the large number of cases, don't do anything. You can use a TSH level of 34 between 24 to 48 hours as per as the ISPE criteria. 20 to 40, repeat after 14 days. More than 20, consider FT4 in treatment. Less than 10, no treatment. If it's again in borderline, repeat it again. If the levels are less than 6, then clearly treatment is not required. More than 20, again, it may be a delayed rise, do treatment. If it's 6 to 20, you can consider treatment and do other causes like do a scan and other things in that perspective. So this approach is something which will really help you out in terms of overall assessment. Now, very importantly, if there is a premature child, if there's a child with trisomy 21, same gender twin, or hospitalization, you can miss it. They maybe have false negative screen. You need to do a screen again after 2 weeks. Now, what about preterm? So in preterms, again, we use the same TSH, again, day 3, if it's less than 10. So the figures here are lower because the rise is blunted and it may be delayed. So less than 10, you again repeat it 2 to 4 weeks. If it's more than 10, you have to be really concerned before you start treatment. If your FT4 is low, and again, your second TSH is also high, you may consider treatment. If your FT4 is normal, TSH less than 10, repeat it again after a couple of weeks. If you, however, have a bizarre situation of low FT4 and a low TSH, that means it could be a transient hypothyroxemia of prematurity, or it could also be a multiple pituitary hormone deficiency. So if there is midline defect, if there is micropenis, there is hypoglycemia, cholestasis, then you can consider MPHT. If not, then ideally you should do a FT4 using a equilibrium dialysis. If it's normal, no need of treatment. If it's low, then you have to consider treatment from that perspective. So what dose to use? So if clearly, if you want to look at the screening, of course, if your TSH is high and FT4 is low, this clearly means there is no point waiting, treat immediately. If TSH is high and FT4 is normal, if the TSH is more than 20, persistently start treatment, and as weeks go by, your threshold will come down. So maybe if it's more than 6 at 3 weeks, you start treatment. If the TSH is normal and FT4 is low, this is an unusual scenario. You do a FT4 by equilibrium dialysis. So day 4, child with TSH of 22, Dr. Nimisha, what will you do? So it's at the borderline stage. So at day 14, it's 12. It's 9. So this TSH is not going down. Yes. So you need to think about, because you cannot persistently say that, okay, so best would be to do a scan. And otherwise, if you are not able to do that in that perspective, you may need to really look at that. So we have got the approach pathway, which will guide you in that perspective, and then it will tell what to do. So basically, this is a malingering amount of TSH. Better would be to do a scan to identify the cause. So 20-year-old girl with TSH of 28. What do you think here, Dr. Sandeep?
For 20 hours, screening from this level, the screening is done early. We should repeat after 72 hours.
So this is the first case we talked about. There's no point to have been done at this point of time. So this is not required. Repeat screen was normal. Now, once you confirm hypothyroidism, your next job is to look at other features and causes. So carefully examine for a family history. We just had a family today in which father and 2 sisters have congenital hypothyroidism, which basically means it's an autosomal dominant. Usually it is autosomal recessive. So consanguinity, congenital hypothyroidism, maternal becomes important. You may have maternal causing in 2 children that you can explain using TSH antibody. But with father, you cannot explain it. Medications, of course, we talked about iodine in the mother, iodine in the child. Amiodarone is a drug which can cause everything. It may cause hypothyroidism, it may cause a thyrotoxicosis, it may cause a increased production or damage or whatever condition can happen with that. Always look for malformations and cardiac examination. As Dr. Sandeep said, you don't need to get an echo, but do a cardiac examination. Palpate for the thyroid. So ask the mother to basically put the child in the lap and the neck becomes extended down and you try to feel for resistance between the thyroid and the tracheal cartilage. If you find no resistance, it means that the thyroid is most likely not there. What is the size of thyroid at birth usually? Compared to the size of the whole body, is the thyroid smaller or bigger at birth? I mean, if you take a ratio of an 18-year-old child, thyroid per per kg of body weight and newborn, thyroid per kg body weight will be much more. Which other glands are big at birth? Adrenal, uterus, and testis. They will also be bigger in that regards. So hearing becomes important because you can have a hearing abnormality. The neurogenital anomalies are common. Thyroid scan is something which is going to help you out, particularly giving information about sight and function. And we usually use technetium 99, which is a more fast scan. It gives you result within half an hour. It should be done after feeding because if somebody, the salivary glands have a lot of iodine intake. So if you are fed, then this chance of iodine uptake will become less. Should ideally be definitely done before treatment. And if TSH is more than 30, you can also do it. So if somebody has TSH of more than 500, somebody has started, you can do it after 3 to 4 days. Remember, do not wait for the thyroid scan to start treatment. Do not delay treatment. If possible, do a scan. If not, doesn't matter. You can reassess again later on. So you may have an absent gland, you may have an ectopic gland, and this is the scenario where you may get the lingual thyroid, as Dr. Sandeep was talking about. You may have a hemiagenesis, only half the gland is there, or your whole gland are there. This is a utopic thyroid. This is dyshormonogenesis. So scan gives you a good picture. You can, and some people do a perchlorate discharge test. We do not. It is a marker of organification. So iodine has gone in, but gets discharged, which basically means that you're not organified that. So it's negative in thyroglobulin and pendrin, present in NIS and TPO problem. And the main role of thyroid, I would say it's not essential. The major role will be if you have this malingering, a persistent TSH of 6 to 10, transient causes, this may be helpful. Especially if you have a goiter, this is something which can give you a clue. Another good modality is thyroid ultrasound. And a lot of people talk about, okay, the radiologists are not attuned to thyroid ultrasound, but remember, thyroid is much bigger at birth. So they should be able to tell you whether the thyroid is there or not. That's what you're looking at. And they don't have, of course, role in ectopic thyroid. So how you can classify? As I said, if the ectopic, of course, you will be able to identify. There's no confusion. Dysgenesis, you will have absent on scan, absent on ultrasound, and undetectable thyroglobulin. If you have absent on scan, but ultrasound is showing that you have got the gland, then of course you have got an apparent athyrosis, which is TSH antibody, iodine excess, TSH receptor defect, or NIS defect. So I think this is what very clearly Dr. Sandeep talked about. If, however, you have got a enlarged gland, then you're talking about dyshormonogenesis like TPO, pendrin, iodine deficiency, and the only situation where thyroglobulin will be low will be a thyroglobulin deficiency. So if you look at these two, you can pretty much classify. Thyroglobulin has got a corroborative load. So I don't usually would suggest that you do a thyroglobulin, do ultrasound, and if you have scan, that is something which is good enough. Genetics is not really recommended, but if you want to do that, if the gland is there, like in this child, we had the gland which was shown. There are extra thyroidal manifestations that you're looking at and as a family history. So this will basically be a segregating scenario. And that's why you can consider doing a genetics. Hearing development becomes important. So thyroid scan shows ectopic, your job is done. Thyroid scan shows increased uptake. It could be dysharmonogenesis, iodine deficiency. Remember, urinary iodine is not a good marker of iodine status. It's a good marker from a community perspective. If the urinary iodine is extremely high, what does it mean? So this means exposure, like either amiodarone, drugs, or iodine, this thing. But otherwise, iodine deficiency, it's not a good marker. It's more for an excess marker. If the scan is absent, get an ultrasound. Absent shows agenesis. If it's present, then this is most likely a case of a transient or a athyrosis. Do a TRAM antibody, it's present, it's maternal. Absent, it is NIS or TSH defect. So this is how you can approach it. So this is day 2 girl with screening, TSH 28, advice treatment, Dr. Vibha. And repeat TSH is 12. What do you think is happening?
Repeat TSH is done
After a couple of weeks.
like after 14 days.
Yeah.
So it is less than 20, so generally no treatment is.
So clearly the level is not very high. So this was too early. This is our first case. We had done it much earlier. So repeat TSH is normal. So it is not going to be of relevance. Day 3 boy on neonatal screening, TSH is 24. And what we are seeing 14 and then 9. I think this is something which we discussed earlier also. This is hemiagenesis. So this is the case which Dr. Nimisha had discussed. Day 3 boy with screening, TSH is 3. Has lethargy and weakness. 1 month later, the child presented with a TSH which was much higher. Now the parents are saying you did the screening test, but still the child now was missed. What could be the possible causes that we have missed out? This is not a preterm child. This is not child who required hospitalization. So what other history will give you a clue? Of a false negative screen. So what things you'll ask? Dr. Sandeep?
Maternal maternal steroids, history of prematurity will ask.
Prematurity is not there.
Yes.
So thyroid scan showed no uptake. So basically you have to think of prematurity which is not there, trisomy 21 which is not there, hospitalization. So this thing is often missed. So why is that you may have a normal screen at birth in a same gender twin? Yes, so twin to twin transfusion, the one child was giving thyroid to the other child, and that's why you missed it. So very important, this is something people miss. Prematurity, everything else people do, but same gender twin, you have to think of a possibility of twin to twin transfusion. And that becomes important. 32-week neonate on routine screening, TSH is 7, FT4 is normal. What will you do?
22 weeks is the premature.
Yeah.
So we have to repeat it and we should do the equilibrium analysis for the T4 again, then see what is the
Okay,
level.
yeah. So on repeat, what you are finding is TSH at day 14 is 14. So this clearly you will need to probably treat because, and then of course you can do a FT4, but clearly this is a delayed surge as we discussed in a preterm child. 28-week neonate, TSH is 22, Dr. Sandeep. FT4 is low. What is your approach here?
So for 28 week prematurity, the TSH is high, sir.
Yes.
And T4 is also low, so it's a primary hypothyroidism.
So remember the physiology. In preterm, you expect TSH to be low. High TSH is very, very significant, which means the actual TSH would be much, much higher. So this clearly is a scenario where you have to treat. This has to be some other problem. So low TSH may expect, but high TSH is very significant. Despite prematurity, your TSH is high. That is the message. So 28-week-old boy with RDS, TSH is 12. FT4 is slightly on the lower side. TSH is 8. What do you think? It's coming somewhere around this region.
Then defects and micropenis.
Yes, yes. So what we found here, there was micropenis which was there. So this was more likely to be a central one. So I think what I'm coming on to that, you look in the child. Don't just say that every report in a premature child is normal. Look at the whole picture and then decide about the need for evaluation and management. 29-week-old girl, ICU admission, TSH is 14. FT4 is on the lower side, TSH is 8. Again, same scenario. So what will you do, Dr. Vibha?
Like whether there is the cortisol level high is low and high will go towards this stress and the low will go towards the
Yes. So there are no midline defects and further workup, equilibrium dialysis, which you mentioned earlier also. And then if you do cortisol, that will give you a final picture. If cortisol is low, this is MPHT. Cortisol is high, you will go in for more favor of a stress scenario. Day 10 child TSH more than 100, FT4 is very low. Now thyroid scan showed no thyroid tissue. The parents have been told lifelong treatment is required. Do you agree?
We have to do scans. We have to do ultrasound, sir.
Okay, so ultrasound becomes important, and this ultrasound showed a utopic thyroid, which means that there may be a chance of reversal. It may be a sodium iodine symptomatic defect, it may be a TSH receptor defect, but it may also be a TRAB antibody. So, in this scenario, you expect it to cross over that. 3-year-old girl diagnosed at 2 weeks, well controlled, everything is normal, always the thyroid was normal, but she has a speech delay. So, what went wrong? Yes. So screening becomes important. It could be with or without pen rate. Definitely pen rate is an important thing to look at, but other causes are there. The most common manifestation of pen rate syndrome is hearing abnormality and not hypothyroidism. Remember that this is something to remember in that regards. 2-year-old girl with severe developmental delay, low T4, normal TSH and high T3. So this is what we discussed. What do you think here? Yes, so this is one feature where T3 becomes important. So if you're thinking of not like hypothyroidism, but developmental delay, do a T3, T4, TSH. This becomes important. There are extrapyramidal symptoms, it's MCT8 defects, and you can consider the thyromimetic as we discussed. 3-week-old boy with lethargy, TSH is very high, FT4 is very, very low, increase uptake on thyroxine 15 microgram per kg per day. TSH is more than 100. The dose was made 25 microgram per kg per day. But despite that, TSH is not budging down. Do you think this is reset axis? And FT4 is also low. So this is a very, very characteristic finding of consumptive hypothyroidism, wherein you are able to metabolize the thyroid very quickly. So treatment, of course, the only treatment is thyroxine, no role of T3. However, there are few people who are now suggesting that in somebody who has got a severe hypothyroidism, you may give T3 for some time because T3 has a faster half-life. So it will have a quicker onset of action. Something like when you treat hypocalcemia because of vitamin D deficiency, you give a calcitriol for some time. So maybe T3 for a couple of weeks. This is something which can be considered in severe cases or late diagnosis. Somebody is coming to it 3 weeks, 4 weeks, you can consider that. Use the same brand, use the tablet. There are a couple of preparations which have come in the Europe with regards to the thyroid replacement in the liquid form, but not in India. So only preparation is the oral one. You use dose, I'll talk about what dose is good enough and give it ideally 4 hours after feed. You basically break the tablets, dissolve in the breast milk and give it to the child and try to avoid with other agents and other features. So if your FT4 is exceedingly low, go with the highest dose, 15 microgram per kg per day. If it's 5 to 10, start with around 12.5. If it's more than 10 normal, you don't need to give that high, you can go 8 to 10. So this will be complete agenesis. This will be more like dyshomogenesis, and this may be a transient phenomena in that regards. And then you titrate, do a level after 2 weeks. We want the FT4 to go sky high. If it goes to 30, 40, 50, don't bother. We want it to be high. TSH will take time. And then 4 weekly. And target is a higher level of FT4 with a normal level of TSH. But remember, TSH may take time. So if your TSH is high and FT4 is normal high, you continue same. You do not increase the dose. Of course, if FT4 is low, there is no confusion. If, however, your FT4 is high, you may consider somebody says 25, 30, I don't bother. I don't want to come down because the weight is increasing. So automatically per kg, you are reducing. If, however, your TSH is low, of course, the dose has to be reduced. So day 4 child with TSH more than 100, dyshomogenesis, LT450, a reasonable dose. At 4 weeks, FT4 is on the higher side, TSH is also high. How much dose will you increase, Dr. Vibha?
We do not need to increase the dose because TSH will take time to come down and FT4 is high because we have started.
So this is the resistance to thyroid hormone basically. So don't need to increase in that regards. It's the same dose to be continued. Now, when to reassess? So some situation you may get patients who come to you late. They already been started on treatment. You find it's an ambiguous one. Maybe TSH was 10 or something and somebody started. Don't rush to stop it. Because main aim is to err in the side of treatment and not missing the diagnosis. So if TSH had been less than 40 generally, the dose has not increased over time And dose is pretty low now because somebody started around 25, he stayed on 25. So it will be like 2.5 microgram per kg per day. That is a good predictor in terms of responsiveness. Usually we don't do it before 3 years of age, stop for a month and do a TSH again and then go from there. In that perspective, the outcome basically depends upon when you treat. For 30 days and above, you have 15-point IQ loss. There may be subtle features like hearing loss, strabismus, and other things which are also there. And FT4, bone age becomes important. So some people do a X-ray of the knee to document fetal hypothyroidism. There'll be no epiphysis seen there, so that could be a good sign. And of course, how much dose you have given. There's one question from Dr. Adele. Our adolescent complained of fatigue and goiter. No other features of hypothyroidism. The TSH is undetectable and T4 upper limit of normal. So looks like a subclinical thyrotoxicosis. Ultrasound showed an enlarged hypovascularized thyroid. TPO, TG, and TSH receptor are positive. Okay, she was started on carbimazole since 2 weeks. The problem control of TSH and T4 remain the same, and she will complain of tiredness again, and even more compared to before starting treatment. So you are on carbimazole. This will most likely be a sort of a scenario of subclinical thyrotoxicosis. Often we do not treat it, and it's unlikely that these symptoms will be because of this level of hormones. So better would be to wait and watch and look for other causes. If we treat it, we may actually induce hypothyroidism. So better to avoid these treatments here. The only treatment which is indicated in subclinical thyrotoxicosis is older individuals who have atrial fibrillation or those who have got osteoporosis. This is the risk factor, not in children. Very unusual for children to have subclinical thyrotoxicosis.